Were you able to hear that, Dr. Wall?
Basically, clinical factors versus response to chemotherapy, and how do we make our radiation recommendations? We're basically awaiting the level 1 evidence from the NSABP NRG trial. In the Mamunis study, where they retrospectively looked at recurrence risks in their NSABP 18 and 27, the response to chemotherapy was the strongest predictor for local regional failure. So today we look at both, but right now it's very hard to withhold radiation therapy in patients who are maybe clinically node positive and then convert to node negative. We on the whole tend to recommend radiation therapy in those patients, but there are cases where we can have a intelligent discussion with the patient, and if they're highly motivated to avoid radiation therapy, that's a choice that they may make. But on the whole, that'd be the rare patient. We would encourage enrollment on the trials.
Thank you.
Thank you.
Yeah, especially where so much of the clinical data that we have is tied to clinical presentation, but as we learn more and more, I think, as Dr. Wall points out, some of it is time to bear out and see how treating who will differentiate the groups. Dr. John?
I meant to cut you off. Just have another question for Dr. Wall. Can you comment on the radiation field if you have a triple negative disease with N1, clinical N1, but after post-mastectomy, after lumpectomy, would you cover the lymph nodes still?
So with ER negative disease, I have a very low threshold for treating regional nodes. That groups tended to benefit the most in the MA20 trial, which is a randomized trial of patients with 1 to 3 positive nodes. Half got regional nodal radiation therapy after lumpectomy, half did not. I just generally think of our triple negative patients as being bad actors and would tend to err on the side of treating the nodes.
So even with PCR after adjuvant?
Yeah.
That's another question to Dr. Yan.
Yes.
So in your data, seems if you suppress RAC1, the normal cell doesn't seem to get affected. So, but we do see the normal cell expressing RAC1. What do you think is the physiological function for this gene in normal tissue?
So RAC1 in normal tissue is a very low level compared to the cancer. So we think normal tissue probably they're not addictive to the high level RAC1 for survival. So I think during the selection, especially the radio-resistant cells, they are expressed 3 to 5-fold higher RAC1 for survival reason. So that's, I think, as a RAC1 inhibition, there is a differential effect toward the normal versus cancer.
My question is for Dr. Tandra. Over the years, your conversations with patients must have become a lot more complicated, especially now we've got results of CREATE-X, and we're introducing maybe capecitabine in triple-negative breast cancer patients that don't respond to initial treatment. Are you finding that you have to provide more educational material for your patients, or how is that changing the conversation you've had with patients on that initial consultation?
Dr. Tandra, would you mind pressing the button?
All right. The question was with the availability. I need to hold it, right? Okay. Sorry. The question was with the availability of new data, especially in the post-operative setting, in those patients who were given neoadjuvant therapy, neoadjuvant systemic therapy, in patients with residual cancer burden, we have data available, level 1 data, that capecitabine improves the progression-free survival and overall survival So with the availability of this information, which is recently new, like a couple of years ago, how are the conversations changed with patients? So, well, you know, the conversation has become more difficult, especially for those patients. What we do in the medical oncology world is we usually prepare them for that a possibility that, look, we giving you chemotherapy, the hope is that we get a complete response. And chances of response are the probability of response is up to 70% in triple negative disease and HER2 positive disease. So there is always a chance that we may be talking about giving additional treatment with additional chemotherapy. So we kind of prepare patients for that. And we also give them information about what occasions going to be, what are, you know, under what circumstances we are going to give capecitabine, like any disease left behind. The way I put it to my patients is any cell left behind. I want a complete response. I want every cancer cell to be killed. If it's not going to happen, I think we need to give capecitabine. So it's all about discussion and preparation of the patient. Usually I do that for younger patients, less than 50. And patients with the significant comorbid conditions and patients who are really old. And if I believe that the capecitabine is going to do more harm than the good, I usually tell them that let's see what happens and then we will decide. Did I answer your question? Yeah.
Thank you. Dr. Wall?
My question's for Dr. Maxwell. So I get this question often from patients and residents. And when we talk about doing sentinel node procedures, and what we do here is this, the TAD and sentinel node, we have to get at least 3 nodes. When you're in the OR, how do you know you have 3 nodes versus 2 nodes versus 6 nodes?
Sure, that's a good question. So it's a little bit, so essentially what we do is for the sentinel node targeted axillary procedure, we localize the clipped node with a radioactive seed most of the time. But we also do a standard sentinel node procedure in addition to that localization. So standard sentinel node dual tracer identification has been shown to decrease the false negative rate significantly and is especially important post-neoadjuvant. So that's what the Sentina trials, the Canadian SNFAC trial, and the American trial showed that dual tracer techniques decrease that level significantly. So what we do is we localize the clipped node with the radioactive seed, but we also inject Tec-99 as our radioisotope and blue dye in the preoperative setting, which is how we do our standard sentinel nodes. So in general, we rely on the radioactive seed to identify the previously biopsy-proven positive lymph node. Once we remove that, we change the setting on our NeoProbe to identify the Tec-99, and so then we take out any lymph nodes that are hot and all lymph nodes that are blue, and we send everything for frozen section to our pathologist. And I usually you can usually tell when you like, you can count how many lymph nodes you're pulling out when you're doing the sentinel node, but I never ever move straight to dissection if I've only had 2 specimens come out, because sometimes the pathologist will look through it on frozen and then say, in this specimen you have 4 lymph nodes and you thought it was, you just pulled out 1, and it could be a few small ones stuck together. So really we rely very heavily on the pathologist for frozen section to count the exact number of lymph nodes. And they'll call back into the room and tell you exactly how many lymph nodes you have. So that's how we identify at least 3 nodes. But I always caution our residents and learners when we do this, it's just if you only pull 2 on your targeted and sentinel, it doesn't mean you have to immediately jump to axe dissection, because we wait for the pathology to come back to identify the true number of lymph nodes, because it happens a lot where you think that you've got 1 lymph node, but it's a little chain of 2 or 3 small lymph nodes stuck together that come out as 1. Especially when you're doing the seed localized lymph node, we tend to be a little bit more generous in the tissue that we remove for that, because it can be quite challenging for the radiologist to place the seed directly into the node, like through the capsule of the lymph node. And so oftentimes it's in the fatty tissue just adjacent to the node. So you don't want to come right down on top of the node, because you could dissect out the node but leave the seed or the clip behind. So we're a little bit more generous in what we take out there, and that often means that little nodal bundle that we take out has a couple lymph nodes in it.
If it's okay, a follow-up to that, the technetium and blue dye, also locating that clip. Those would all be considered a part of the sentinel lymph node biopsy. In addition to that, makes it a targeted axillary dissection?
So the localization of the clipped node with the radioactive seed or wire in some cases, although that is understandably much more uncomfortable for the patient, is what really makes it a targeted axillary dissection, in that you're targeting the biopsy-proven clipped node that you knew had disease in it pre-treatment. That's really the biggest differentiation between a standard sentinel node. In some institutions, they do not localize the clipped node with a seed or a wire. They just do a standard sentinel node and then image the nodes to see if they have the clipped node, because theoretically your positive node should be one of your sentinel nodes if cancer travels through the lymphatics the way that we think it does. So in some institutions, they do not actually localize the clipped node. However, I think that there's some data that shows that leads to a slightly higher rate of completion dissection because you can't find the clip node. We do that here if for some reason our radiologists are unable to identify the clip node. If they've had a significant treatment response, it can be really hard for the radiologist to see the node with the clip in it and get to it. So we still do it that way if we can't find the clip node. Do a standard sentinel and see if the clip is in it. But really just the removal of the clipped node specifically is what makes a differentiation between a targeted and a sentinel.
And do you see any difference in lymphedema between, say, a lymph node versus that targeted axillary dissection?
I don't know that we have published data on it, but anecdotally, no. I think it's, you're not dissecting really anything more than you would be with a standard sentinel node. So there's not an appreciable difference in lymphedema rates.
Thank you.
Jessica, sorry, the same question. What if you cannot find the clipped node during the operation? Are you going to do complete axillary lymph node dissection straight away, or would you just wait?
Yes, so that's the indication. That's one of the indications to proceed to complete dissection, is if you cannot localize the clipped node during your sentinel node or targeted.
How frequently that happens? Do we have any data?
No, it's usually we can identify it. I would say probably since I've been here for 4 years, and we've been doing this pretty much since I got here. I would say there'd be less than 5, certainly less than 10 cases where we could not identify a clipped node. And that was the reason we did the complete dissection. Most of the time it's the disease, residual disease on frozen, that drives us to do a complete dissection. Just like it's very rare that we would not be able to identify 3 lymph nodes to send for frozen section, or have our pathologist identify 3 lymph nodes for us. So usually the driver between the conversion from a targeted to a complete would be residual nodal disease.
Thank you. Dr. Zen?
Thank you. This question is for Dr. Wall. Actually interesting, the first time I actually learned that triple negative disease could be also radio resistant disease. So, because if you look at the head and neck cancer, so the way we try to overcome radio resistant disease is by doing dose escalation, for instance, is by adding radiation sensitizing agents such as chemotherapy. So is any attempt to do that, like adding radiation sensitizer for triple negative disease when they're receiving radiation therapy, or is there any room to escalate dose of radiation?
I don't know of any data of escalating the dose beyond 60 to 66 gray if you're doing a lumpectomy and a boost. So I don't think that's being discussed as much in terms of addressing these patients in terms of protocol development. I think what is being discussed is adding neoadjuvant or adding concurrent therapies. So there's been a phase 2 trial of paclitaxel. I think at Michigan they're using an androgen receptor antagonist. I think enzalutamide in a phase 2 trial. So I think that's going to be the approach, is more of a biologic approach and not a radiation dose escalation approach.
Thank you. And also pertinent to Dr. Zen's question, I'm aware of some preclinical data with triple negative breast cancer when treated with a RAC1 inhibitor. Is there anyone in the audience that could make any comments on that? I'm sort of teasing, but Dr. Yan, what are the next steps for bringing RAC1 inhibitors into the clinic?
Yeah, so the challenge for the RAC1 inhibitor is the current available first generation requires 100 micromole. Second generation requires 1 micromole range. So we wanted to reach the nanomole range to be able to use in vivo study. On the other hand, those inhibitors seems not toxic because we treat the mice with the second generation, which is discovered by the Australia group. And the mice seems fine, and there is no any toxicity being observed except doxorubicin. So the one we discovered is at a 1 micromole range also. So we wanted to modify this drug further to make it more potent. Second modification we want to do is to make the drug stay longer in the blood because that drug did not pass the pharmacodynamic study. Did this clear up by the blood too fast? So this is the challenge. There is no inhibitor available anywhere in this world right now. So
very interesting.
But on the other hand, I didn't have a chance to mention one of my data, which is very interesting. I created a bunch of cell lines express inducible RAC1 knockdown. So when we inject the mice with 20 million cells, make it grow into the tumor 1 millimeter size. After that, we use the tetracycline to turn the knockdown on to decrease the RAC1 expression. Then I was going to treat the radiation to see what the radiation does to that synergy. But to our surprise, tumor disappeared complete 2 weeks later. So we could not treat any drug or radiation. So we went back to re-inject another 20 million cells to induce tumor again for many weeks. And when the RAC1 turned on again, tumor disappeared again. So we did not able to do any drug or radiation treatment. So that says maybe RAC1 alone could function as a single drug. That's my hoping.
Very interesting. Dr. Lin?
I have one more question for Dr. Maxwell. So for those patients, let's say, started very advanced, like a T3 or even M+, and then after the chemotherapy is all gone, you don't know where to do the lumpectomy, but if you do the mastectomy, it's too aggressive because the CCR, will you just let the radiation to take care of it, or what do you do?
So is this for patients who have had a complete radiographic response? You're asking how do we identify the area to do the lumpectomy? So you really have to depend on radiology to place biopsy clip at time of diagnosis, which our radiologists do. So even if they do achieve a radiographic complete response, we still have a target to localize. And we'll often do, like in that situation, a seed localized lumpectomy. So the same radioactive seeds that we use to localize the lymph nodes, we would use in the breast to localize that area. And then the question then becomes, how much do you take out? And it's usually just kind of, I always try to take kind of a representative sample of that area so that you're helping to rule out the potentially of kind of skip lesions and like kind of in, not total kind of concentric shrinking down of the tumor on chemo, but kind of having areas where you have response and areas that you don't. So we take out a fairly large area. I say that one of the benefits of oncoplastic surgery is that you can take a fairly large specimen out without significantly compromising their final cosmetic outcomes. So there's good data that demonstrates that the positive margin rate and the specimen weight and volume is significantly, the positive margin rate is significantly lower in oncoplastic surgery, and specimen weight and volume is significantly higher. So you can actually localize and take out a very fairly large area of breast tissue, depending on patient body habitus, and still do that. But we do need to know where to go. So that's why we have the radiologist mark the area with a clip. And in patients who do not have clip placement prior to neoadjuvant chemotherapy, really for the most part, we're committing to a mastectomy at that point to ensure that we're not leaving disease behind. One of the benefits of our multidisciplinary clinic is that we're able to review all these patients before they get any treatment, and we review their imaging. So if for some reason a clip was not placed, we could send them back for clip placement prior to treatment so that we avoid that situation.
So is there any data that what percent of CCR actually is the PCR?
Sorry, could you say that again?
What percent of CCR is PCR? Meaning, is there any way that you think the CCR, when you go in, they are actually most of the patients, they are all truly gone. Then you don't need to do surgery, just radiation.
Yeah, I think that's a good question. I don't know that we know the exact number. There is some data that suggests that MRIs are one of our best radiographic tools or radiologic tools to predict that. But even that success in breast is only about, I think, 63% at the last data that I showed. So, I mean, it's good, but it's not perfect. So I think, you know, that's why we joke about breast surgeons eventually being out of jobs, is if we can get everybody a PCR and give them radiation, maybe you won't need surgery anymore. But until we have better way of predicting that, I think surgery is really the only option to prove complete response, which can be a challenging conversation to have with patients who come and say, well, I don't want to have surgery. My MRI shows that everything looks good. Can they just have the radiation? And I always say, well, we have to prove that things are as they appear. So that's sometimes a challenging conversation.
Dr. Katu?
My question is for Dr. Wall. I think the question on the chat is kind of interesting. They ask, do you radiate patients with triple negative T3N1 disease who have a complete response after chemo and mastectomy? And I have a follow-up question after that.
So the answer to that would be yes. The patients with stage 3 disease in the early MD Anderson trials had high rates of local failure in that PCR group, but that was not ER specific. The NACBP analysis, the risk of a local failure for all comers was actually 0% in something like this, but the number of patients in that bin was 11. And the CT-NEO BC analysis that I presented, the risk of a local failure was about 5 to 10% in this group. A third of those patients had radiation, so you'd expect it to be higher. And the number of patients in that was under 100. It was like 50 to 100 patients in that bin. So we're really looking at retrospective reviews of well-done prospective trials to make conclusions about radiation therapy. And until I've got better evidence that I can avoid it, this is somebody who I would radiate.
Then my follow-up question kind of goes into what you're saying. We are anxious for the results of the B51 trial. We know we won't get that for quite a while still, but what would it take to change the practice so you don't radiate these patients in terms of outcomes and follow-up from that trial?
In lieu of a randomized trial, what would change?
Yeah, correct. What would have to happen for us to not radiate these patients?
guess I'd have to have a large retrospective review of standard procedure in terms of we either prospective or retrospectively did not radiate any of these patients, and we have hundreds of patients with long-term follow-up. I guess it'd be better evidence than what we have, higher numbers of patients, et cetera.
Any other questions?
Dr. Wall, can I ask you a question? In one of the slides you showed us, basically the factors in the multivariable regression analysis, the factors which really you're looking at initially at the time of staging were ER negativity, I think, which has the highest points, 2 points, and the clinically node positivity, and a couple of other things you looked at, and PCR is one of the factors as well. So my question to you is, can't we make a decision whether to radiate or not at the time of, before we give the neoadjuvant chemotherapy, because most of those factors we already have, ER negativity, clinically node positive or not. So the only factor which you're looking after the neoadjuvant chemotherapy is a binary answer, yes or no, PCR or not. So sometimes that might help Jessica whether to do the complete dissection or not. So if we can make the decision beforehand.
Yeah, those situations we're looking at T3, T4 disease. We look at number of nodes if we have a PET CT. We know the tumor biology. And so I tell those patients that it's highly likely that I'm going to recommend radiation, so they're mentally prepared for that. And basically sometimes just outright tell them. Now, the question is then whether or not we can make surgical decisions based on radiation therapy recommendations. And right now, we can't routinely do that. It is a difficult conversation to have with patients when we proceed with the dissection for patients with micromets or patients with isolated tumor cells after neoadjuvant chemotherapy. And clearly the morbidity of radiating the axilla and supraclav is less than when we combine the two with a dissection. So those situations comes down to tumor biology and the extent of nodal involvement. But we do have data that patients with micromets after neoadjuvant chemotherapy have the same prognosis as those with macromets after neoadjuvant chemotherapy. There was one study that looked at micromets. Patients with micrometastatic disease have a similar rate of having additional nodes positive on a dissection as somebody with a macromet. So they're difficult conversations to have with patients, but I don't know if we could tell Jessica right away what to do until we see what comes out.
Thank you.
All right. Oh, another question?
Yeah, this question is for Dr. Wall. I do have this is in back of my mind all the time that radiation does cause the ROS production. It's radiation does cause ROS, reactive oxygen species induction. Radiation induced the ROS, reactive oxygen species. Yeah. So ROS has one significant role is to inhibit the receptor tyrosine phosphatase activity. So which means EGFR or the like RAC1 will be fed by this integrinase pathway. So there's any evidence to show that the radiation can cause the local failing because increased cell invasion or migration or?
No, there's no data. Almost all trials show a benefit in local control with radiation therapy. Sometimes very small, but measurable.
All right. Thank you. Many good presentations, a great discussion. We're going to conclude 5 minutes early and break for lunch, and we'll be back at 1 o'clock.